Our next session is on clinical trials in adult patients. This will be presented by DSF Scientific Director, Dr. Veronica Hood. Veronica joined DSF in 2020. She has an MS in biology from East Tennessee State University and a PhD in cell, stem cell, and developmental biology from the University of Colorado. She spent 10 years in laboratory settings researching how small changes in genetic and molecular regulation contribute to complex neurological diseases. In 2007, Veronica had a son, Gabriel, who faced severe developmental challenges. Gabriel presented with initial seizure activity within his first 2 months of life, and his medical needs quickly became quite complex. Despite endless testing, a diagnosis remained elusive, and at the age of 8, Gabriel passed away. These experiences fueled Veronica's passion to advance medical research and shaped her desire to support other families facing similar challenges. She hopes to apply her scientific knowledge and her understanding of the caregiver experience to support the Dravet community by facilitating Dravet-focused research and acting as a liaison between researchers, professionals, and families. Veronica currently lives in Tennessee with her partner, Scott, and their pets, and enjoys being outdoors in her free time.
Hello, everyone. Thank you, Marianne, for that introduction. As she just told you, I'm Veronica Hood, the scientific director at DSF. And today, the title of my talk is Clinical Trials in Adult Patients, but I'm really going to talk a little bit broader than just that. I want to talk about what we know about adults with Dravet syndrome, what the current barriers are to progress in research and our understanding, and what families really see as their major challenges. And then I want to talk a little bit about what we kind of hope for the future of this research. And so I just wanted to start a little bit with what do we know about Dravet syndrome in adulthood and go over a few of the common characteristics. I do want to just add a reminder that I think most of you by this point in your journey are really well aware that almost all the symptoms in Dravet syndrome, I think about it as a slider scale. Sometimes you'll see the spectrum of SCN1A disorders and you'll see Dravet syndrome down at the end and you'll see the spectrum that way. But I want you to also remember that each symptom is kind of on a scale and every patient is unique. And so these are generalizations, but there's a broad range of how these different symptoms can present from patient to patient. So just remember that, everyone's an individual and these are generalizations. But so I'll just start with saying that in 2018, DSF did a survey, and in combination with that survey and some published material, we're confirming that about 80% of individuals with Dravet syndrome do survive well into adulthood. And while we know that, there is a 15 to 20% mortality rate for Dravet syndrome, it does seem that those mortality rates might taper off and not be as high for those who have reached adulthood. But something like SUDEP or sudden unexpected death in epilepsy is still a major concern even in adulthood, and is something families need to know about and discuss with their doctor about what they can do to help prevent the risk of SUDEP. Seizures in adulthood, you might often read in the literature that they begin to decrease in frequency or in length. Again, this is a generalization, and you're going to see that some families are still seeing, a high frequency of seizures. And from that 2018 DSF study or survey, we found that 92% of caregivers indicated that their adult that they care for with Dravet syndrome is still experiencing frequent seizures. However, in general, the risk of things like status epilepticus do appear to decrease in adulthood generally. But I think, related to SUDEP and that's still a major risk factor, as patients age, it seems like seizure activity at night or during sleep does seem to become more prevalent. And so it can really necessitate more sleep time monitoring. There's also a lot of issues with motor function in Dravet syndrome, and there's some evidence that and the motor dysfunction might progress as patients age. And so you've probably heard about the very stereotypical crouched gait in Dravet syndrome, and you may know that some individuals begin to have difficulty with walking or running. And then in adulthood, there's also these very characteristic Parkinsonian-like features. Adults with Dravet syndrome are not any higher incidence of actually developing Parkinson's disease, but something about the pathology in the brain seems to have similar presentations. So you might notice things like slower movement, more stiffness, balance issues, speech impairment, some forward neck flexion or like hanging of the head, a Parkinsonian gait, bending of the spine, and additionally, some behavioral issues that are common across Dravet syndrome and Parkinsonian, which can be hoarding behaviors or sort of perseverating on accumulating specific objects. As I mentioned, seizures during sleep can become more prevalent in adults with Dravet syndrome. And just as in childhood, sleep disturbances still seem to be a major issue and not just related to seizure activity. Unfortunately, there have just been very few studies about sleep and Dravet syndrome in general, and even fewer that are relevant to adults or specific to adults. Intellectual disability is also very common, and some limited reports suggest that along with the motor dysfunction, that cognitive impairment may continue to progress in adulthood, but those studies are still very few to really nail that down if it's a progression or just a plateau. The degree of cognitive impairment can really vary from patient to patient with, anywhere from severe to very mild cognitive impairment. But most commonly, it's somewhere between severe or kind of a mid-range of cognitive impairment in adults. Some studies have also seen that this cognitive impairment can be linked to things earlier in the progression of the disease, specifically if contraindicated medications like sodium channel blockers are used for a long amount of time during childhood, or if a child has particularly severely refractory seizures. Some of these may correlate with worsened cognitive outcomes in adulthood. And then the treatment of Dravet syndrome really remains very similar to what is done for juveniles or children. So you're going to go through the same lines of treatments, but there may be a few different caveats for adults. Like, for example, adults may be a little more sensitive to stiripentol, and so you may need to consider a lower dose than you would in child or adolescents, or you may be more likely to need to supplement with something like carnitine to avoid high levels of ammonia building up. Overall, there's just a real lack of formal therapeutic studies in adults with Dravet syndrome specifically to know if there is a different treatment approach that should be taken. And I just want to reference that in addition to the 2018 survey, a lot of this is coming from a really excellent review that came out of the laboratory of Dr. Danielle Andrade, who's an expert in adults with Dravet syndrome. And she did a really comprehensive review, piling together all of the literature to date that's been published on adults with Dravet syndrome. And so that's where I've sort of pulled some of these common themes. The last point I wanted to bring up about what we know about Dravet syndrome is that from the 2018 survey that DSF did, a third of the patients were not correctly diagnosed until adulthood. And, we really highly suspect that there's a really large number of adults with Dravet syndrome out there who have never received a correct diagnosis. Part of the problem is, that they could be far out from those early childhood symptoms that are so characteristic of Dravet syndrome. And then also there's just a need to continue to stress the importance of genetic testing at any age, but there can still be limitations to access to that. And so we think there are more adults that we just haven't connected with yet. So in addition to these sort of factual things about, here's the signs and symptoms of Dravet syndrome in adulthood, DSF has also polled the caregiver community a few times, and common themes have emerged as top concerns for caregivers of adults. And so on the left here, you'll see top caregiver concerns from the 2018 survey that DSF did. And then this is a 2021 survey that we had about 80 responses to, just listing some of the major barriers and hurdles that caregivers are still encountering. And I think one of the things that differs when you look at these two and you compare to what some of the top concerns are during childhood, seizures really stand out as, one of the absolute top concerns in childhood. And you can see that in adulthood, seizures are still a very important concern, but other things like cognitive disabilities and behaviors begin to sort of, rank above seizures for a concern for caregivers of adults. And I think this is probably twofold. Is probably, some adults are seeing that reduction in seizure frequency or length. And also caregivers are just a little more well equipped at this point to know how to handle a seizure emergency. But, things that really stick out to me in this and areas that have not received the attention that they need would be things like behavior. It can be such a burden. And I think it interplays with a lot of these other terms that you're seeing, such as physical size. And so, behaviors are tough for many individuals with Dravet syndrome, even at young ages. But as individuals grow in physical size, it can become an additional challenge to manage their difficult behaviors. One of the other things that has come out from this is that in addition to just straight medical care needs, there are a lot of needs for social supports in the community. So trying to figure out once adults are past school age, what kind of activities can they do? How can we make sure that they're still socializing and having a full life with good quality? Unfortunately, there really aren't any quick fixes for any of these very difficult challenges, but DSF is working hard to support research in these areas and to develop supports and resources that can speak to each of these needs. We do want to keep hearing from you, and I'm going to, as we progress through this talk, I'm going to tell you a little bit more about ways that we are trying to begin to meet these needs. So one of the first barriers is just that we don't have a fantastic understanding of Dravet syndrome and the progression across the lifetime. So we have small studies here and there, and that's how we've gotten things like the previous slide where I was able to compile some different traits and characteristics of Dravet syndrome in adults. But we really need more research to better understand this and to better understand, advanced age in Dravet syndrome. And one of the ways that we can do this is through natural history studies. Natural history studies are observational studies that aim to collect data from a large number of individuals with a specific disease across a significant amount of time. And so these can be retrospective, something like looking through medical records and reviewing them and compiling that information. But the best way to do a natural history study is prospectively. So where health data is collected from patients in real time in a consistent manner at set intervals, so you can really precisely find trends across time. As you can imagine, these studies are incredibly difficult because they take many years to complete as you prospectively watch patients age and change and go through the medical system. And it requires a huge effort. And it becomes increasingly difficult when you have disparate medical care systems like in the US, where medical records don't always easily talk to each other. Now, natural history studies are important for several reasons. These studies can help increase our understanding of all the signs and symptoms of Dravet syndrome. And then they can also really help us understand the efficacy and how frequently different treatments are used in Dravet syndrome. And Another important part of this is that once you understand it, then you can study it. And so if there are signs and symptoms that we don't really understand how common they are, then no researchers are going to be looking at it. So this is a really great way to spur research efforts in those areas. Another important part of natural history studies is that sometimes now they can be used to reduce the need for placebo arms in clinical trials. And so obviously this becomes increasingly important as we see therapies advancing to more and more complicated forms like gene therapies, where we really don't want to have to give many patients or any patients at all a placebo. We want everyone to receive the experimental treatment. And so natural history studies, when done prospectively and in a way that you really have a good understanding of the average progression of the disease, then a natural history study, the data from that can kind of take the place of patients needing to take a placebo in a clinical trial, or at least reduce how many patients are needed to be in the placebo group. There are some opportunities to participate in natural history studies. I'm going to tell you about a study that's ongoing right now that if you're interested, you can actually join into this opportunity. It's being run by Dr. Danielle Andrade, who I mentioned previously at the University of Toronto. And this is specifically for adults. It's to look at, what different signs and symptoms have been across their lifetime. And also, she's really interested in better understanding the motor impairments and the gait disruptions that happen in adults. So if you want to find more information about participating in this trial or any clinical trial, you'll go to the DSF website. You can look at our menu under Patients and Caregivers. And then over here under Medical Care, you'll see the Participate in Research tab. And this will take you to a web page where we have all of the actively enrolling clinical trials. And so here I just have this one expanded at the bottom, which is the natural history study I'm referencing. And so you'll see information about the trial. For this trial, you can participate remotely, and you'll find information on how to get involved in the trial at the website. In addition to this study, DSF is also trying to help support a broader natural history study effort that will be occurring in the United Kingdom. And this is going to include both children and adults. It's going to be prospective, and it's a really long-term observational study of Dravet syndrome. We're really excited to support it. We're excited to learn from this study to see if there are ways that we might want to implement similar studies in the United States. And we're really excited to see that adults are being included in this study. And so that's covering observational trials or natural history studies. What are some currently ongoing interventional clinical trials that might be relevant to our adult population? So right now, one actively enrolling clinical trial is a phase 3 trial for lorcaserin, which was previously marketed as Belviq, and it's currently recruiting for patients older than age 2 across the United States and Canada. Lorcaserin is a serotonin modulator, so it's just important to know that this wouldn't be able to be used in combination with other serotonin modulators, such as the recently approved fenfluramine or Fintepla. But it works on a similar mechanism of action through serotonin, but it is a different medication. And so I have heard from a few families that they've had different experiences if they've tried both medications. And so this is definitely something to check out. You'll find on that same clinical trial website on the DSF page, you'll find information on this trial. Another investigational drug, soticlestat, will soon be entering phase 3 trials. This is a trial sponsored by Takeda, and soticlestat works through a novel mechanism by altering cholesterol metabolism. Sites are being planned worldwide. You can see the listing on clinicaltrials.gov. It's not up on the DSF website yet because they're not actively enrolling quite yet. And so once they begin recruiting, we'll have that information listed on our website. This trial will be open to individuals with Dravet syndrome between ages 2 and going up to age 21. So this will be relevant to older teens and young adults. We're also hopeful to see a few other clinical trials that will begin in 2022. So stay tuned and stay connected to hear about those. I think one of the biggest questions that I get and that we talk about right now is, what about gene therapies? And specifically, what about gene therapies for adults? And so when I say gene therapy, what exactly am I referring to? Classically, gene therapy was really restricted to just saying you have a mutated gene and the gene therapy is sending in a replacement copy of that gene. I think the definition of gene therapy is being used a lot more broadly now. And really, these are disease modifying treatments that are acting at the gene level. And so in the case of Dravet syndrome, these are any treatments that are working to correct the cause, which is a mutation in the SCN1A gene that decreases the amount of the resultant sodium channel. And so when I'm referring to gene therapy, I'm talking about different types of therapies that are using genetic material to compensate for that loss of one copy of SCN1A. And so what is the current landscape for gene therapy for Dravet syndrome? Well, it's really exciting. There are actually one company that's already in clinical trials. This is Stoke Therapeutics, and they're testing their experimental treatment, which is called STK-001, and it's using something called Tango technology. Or targeted augmentation of nuclear gene output. It's a really fancy way of saying it's trying to help increase the amount of SCN1A that's produced from the healthy copy of the gene. And this is using an RNA-based platform, and it's called an antisense oligonucleotide. It's given through recurring doses via lumbar puncture. The current trial is focused on safety and efficacy, as well as trying to determine what the best dosing regimen will be to be effective in humans. We just got first reports out from the first year of this trial, and they're really promising. They're seeing some reductions in seizure activity among some of the patients that were earliest to receive doses in the trial, but we're still really early. We're still at very low doses of the experimental treatment, and there's still a lot to learn. This trial is being run for patients who are ages 2 to 18. The other therapy that's really close to the clinic is Encoded Therapeutics. They're using a more traditional gene therapy approach, which is that they're using a viral vector, an AAV packaged gene. So they've basically taken the empty shell of a virus and used it to package up some genetic material that can go in, and it's not replacing the SCN1A gene, but again, it's another gene that can help to upregulate the good copy of SCN1A and restore levels of the sodium channel. This is a little different from the Stoke approach in that this will just be a single one-time dose directly to the brain. The trial is expected to begin adding sites in late 2021, with hopefully beginning to dose patients in 2022. And this study is really starting with children under the age of 5. And so the big question is, why not adults? Stoke is going up to age 18, Encoded is only going to age 5. Where are adults? What can we expect for adults with gene therapies? And there's a couple of reasons why they're not starting with adults. The first one is that it's generally anticipated that prevention of disease or prevention of the progression of disease might be more effective or easier to do than reversing deficits that have already been established. And so that's why a lot of these companies are kind of going in and thinking start with the younger populations, because hopefully that means the trials have a higher probability of success. That doesn't mean that adults will be left off, but that means this is the smartest place to start so that the trial doesn't fail right off the bat. It helps everyone if trials are successful and if we can really see the real true impact of the treatment. Now, this is a general thought that reversing the progression will be easier, but we don't really know. And part of the problem is this is a really difficult question to test in mouse models of Dravet syndrome. Part of the reason is that the mortality rate in mice carrying a mutation in the SCN1A gene is much higher than what we see in patients. So it can be 50% or greater of mice that die either from prolonged seizures or from something similar to SUDEP. And so the mice that do survive into adulthood, you're unsure if there's something different about these mice that have allowed them to survive. And so it just becomes difficult then to determine the actual impact of intervention later on. And so most of the studies have focused on intervention early. And so, for example, the preclinical work in mouse models using Stoke therapeutics showed really great efficacy. And they did try to go into slightly older mice. So instead of doing it before the seizure onset, this was a couple weeks after seizure onset. And they did still see some benefit. They saw some reduction in seizure activity, and they did see eventual upregulation of the gene and the sodium channel. But one thing to remember is that in the mice, at least, when they dosed them at older ages, it did take a little bit longer for the mice to respond to the treatment than it did in the younger mice. So things may look a little different in running clinical trials for children versus adults based on studies like that. And so studies in older patients, kind of piggybacking off of that, may need more sensitive measures or different measures to see how things are progressing. It may take longer to see an effect than it did in children. It may need a higher dose. And when you think about the two different therapies that are going into clinic right now, with things like Stoke, where you're going to need to continue to redose patients for the rest of their life, there's a lot more wiggle room to get that dosing right, to figure out what may need to be different between age groups of individuals. But with encoded, I think it makes sense that they're starting with a very limited age range because this is a one-time dose. And so there's less room for error there. And so I think they're being very cautious in their approach and trying to choose what makes the most sense as a starting point. And then one of the other things to remember too is that when you get into things like viral vectors, there can be risk of an immune reaction. And so this could be things like, from the viral vector. And so you may have different outcomes and different risk factors that you really need to think about when you're looking at adults. And like I said, clinical trials are expensive. We don't want them to fail. A success in a young age group will hopefully lead to trials in older age groups as well. And so it's hard to wait. It's not fair. I'm frustrated with you, but there are, logistical reasons behind why these choices are being made. And it's really hard emotionally to wrap your head around that. But I think it is the reality that we have to work with right now. That doesn't mean that these won't happen for adults. And if these are successful in children, I feel really confident that we will hopefully see expansion to testing them in older children and adults. So what kind of efforts is DSF making to try to overcome these issues? That I've mentioned all of the different challenges to date. And so we're doing a couple things. We know adult neurologists don't know enough about Dravet syndrome. And so as patients get older, they're going to be seeing more and more adult providers. And so we've really been working on awareness and education through a webinar series that we did last year called the Listen and Learn series, specifically for providers, healthcare providers. We currently have a neurology resident education project specifically for adult neurology residents to teach them more about Dravet syndrome. And then we've been working with other groups like the AADMD, which is the American Academy of Developmental Medicine and Dentistry, on working groups focused on intellectual and developmental disabilities and epilepsy. And these are great opportunities to get a broad range of adult providers who maybe aren't familiar with Dravet syndrome. We've also been trying to beef up our DSF Find a Doctor tool with additional resources for adult neurologists. SUDEP is still a top concern for adults, and so we have a lot of different areas where we're investing in either SUDEP research in mice, SUDEP research looking at clinical outcomes and looking at surveys and input from patients and families to understand causes or biomarkers of SUDEP. And then we're also, again, working on professional education resources to make sure clinicians understand SUDEP and are counseling patients on the risk and ways to prevent. And then lastly, one of the biggest needs in the community right now is the difficulty surrounding transition of care. This is a major outstanding hurdle for families, and transition of care from pediatric to adult care can just be such a burden on everyone involved, families, patients with Dravet syndrome, and even the pediatric providers and adult providers have a really difficult time with this. And one thing that is really important is beginning conversations early. And so we recently, just last month, were able to post this great guide to transition patients with Dravet syndrome to adult care. This is basically a 2 to 3 page, depending on where you download it from, infographic that just hits the high points of what an adult neurologist needs to know about Dravet syndrome. This guide could be used in early conversations with your pediatric provider to talk about here's the generalizations about Dravet syndrome. What other things should we be thinking about when we transfer to an adult provider specific to my loved one with Dravet syndrome that we need to communicate? And then when you're actually ready to begin seeing adult providers, either you or the pediatrician can send this guide to the adult providers. In addition, this guide could be really helpful to keep with you, especially if you find yourself in an emergency care situation or unexpected hospital admission, and you're surrounded by doctors who maybe are just not familiar with Dravet syndrome. This can help in addition to having your seizure action plan. This can be an additional supplement to give emergency care providers to help them understand your loved one. In addition to this transition guide, there's also transition programs that are beginning to emerge at major care centers. And while these are really only immediately useful to patients that are being seen at the care centers, I think we're going to learn a lot from these transition programs and be able to apply them broadly. And, we have several ongoing research projects to better characterize all the specific hurdles related to transition of care and to develop even more resources to help families navigate this time. And so in conclusion, there are many hurdles that come with reaching adulthood in Dravet syndrome. And the foundation is really working hard to progress, to make progress in areas of unmet need and create resources for families. You can get involved. Please participate in research when possible and when your loved one is eligible, particularly surveys. I know a lot of you probably are burnt out on taking surveys, but they really do help guide what researchers begin to look into and develop resources for. And then engage in conversations. Let DSF know we want to hear from you. I'm always available at my email. Drop me a line. We can get on a call. If there's a specific area that you don't feel like is being focused on, let us know. And then stay connected. If you want to know about new research opportunities, if you want to know about new supports that are developed, make sure you sign up for our newsletter, watch our blog posts, join us on social media, and get in the support groups. And with that, I'll end my presentation. And I'm just going to need to check over to the chat. And so if anybody has any questions, you can drop them in the chat. If you're not joining us live, you can email me any questions. I do see one question in the chat that I'll answer quickly. Are there any trials or approvals with cannabis with THC included? And I think at this time, the answer is no, at least not in the United States. Most of the research efforts have been at looking at trying to figure out which specific extracts from cannabis might be best to treat epilepsy. And so, of course, we know about Epidiolex that's been approved, but there's a few other companies that are doing preclinical research to try to develop other similar types of medications or treatments, but nothing is in trials at this point in time. I don't see any other questions, but like I said, please feel free to reach out to me at any time. And with that, I'm going to pass it back to Mary Ann, who's going to introduce our next speaker.